Hello class, and welcome to week 1. This PowerPoint is going to review chapters 1 and 2, which is part of your required reading for week 1. And we'll be going over some important terms and concepts from these chapters, which you will be applying for the rest of the quarter. So what is epidemiology? What are we doing in this class? We are studying diseases and their occurrence in human populations. This definition was taken directly from your book on page 4. So why is epidemiology important to you? Well, we look at healthcare related events in people in relation to naturally occurring groups of which they, meaning you, are members. So you are included in our studies, in our observations of what diseases are occurring in populations. If you have kids and maybe your son or daughter was diagnosed with RSV this last flu season, they are part of those numbers, and they are what we use to help calculate our rates of certain diseases and what we can, how much resources are needed and to be allocated towards certain areas. You are a part of all of these things, so epidemiology is important for you, for your family, and for your patients. The study results are directly applicable to the care of each individual patient. So all the data that we gather from reportable diseases, for instance, goes towards research in terms of the start to finish process, meaning for example, if we have say an area with a really high influx of RSV, we know that we can use that data to argue to stakeholders that we need resources and money allocated towards more research for how to treat RSV. And if you guys noticed or heard, within the last few months there has been a lot of talk about a possible new RSV vaccine, and we might be actually getting closer to getting one. The results of these studies are used as the basis for advice about avoiding behaviors that places you at risk, so smoking, sedentary lifestyle, BPAs, etc. I did put in the notes underneath here, BPAs is used to manufacture polycarbonate plastics. So a lot of times like Nalgene bottles, like they advertise that they're BPA free. This is a type of plastic that's used to make some types of beverage containers, compact discs, plastic dinnerware. A lot of products are now advertising BPA free because we know that this is a major health concern. So there's two different types of epidemiology. There's clinical epidemiology versus just regular epidemiology. So clinical epidemiology looks at individual patient questions and population methods, whereas epidemiology as a whole looks just strictly at populations. We do take the data and use that information to help individual patients, but clinical epidemiology addresses individual patient questions. Now, as nurses working in hospital settings or even home healthcare settings, we are primarily focused on patient-centered outcomes. And you can utilize the 5 Ds for this. So we're looking at death, disease, discomfort, disability, and dissatisfaction. So obviously death is a bad outcome if it's untimely. Disease is a set of symptoms, physical signs, and laboratory abnormalities. Discomfort, so symptoms such as pain, nausea, dyspnea, itching. Disability would be impaired ability to go about usual activities at home or work. So this would even include patients who, say, have COPD and they can't resume their normal activities because they're short of breath even though they have oxygen applied. So this would be considered a disability. And dissatisfaction, so emotional reaction to disease and its care, such as sadness or anger. So we are expected to incorporate evidence-based practice in our hospital settings, and this is the application of clinical epidemiology, and we look at these 5Ds as a guide for how we can incorporate those things and where we need to place our focus. Since the COVID-19 pandemic, however, we've really shifted our focus from just single patient-centered to population-centered, because we're starting to pour more time and effort and money into population health, because it really benefits more people when we address it that way. So these are just some basic terms that we need to know. Populations are all people in a defined setting. So example would be all living in California, all those over the age of 65, or all those with thyroid nodules. You could expand this, all those with hypertension. Whenever you're talking about a population, you are talking about a defined setting. So you need to define which population you're talking about. The sample is a subset of people in that defined population. So let's say, for example, you want to talk about all females, and then we do a sample of all females greater than the age of 20. So that would be an example of that. Bias is something that you don't want to happen in your study. Sometimes it can inadvertently happen outside of your control, but an example of bias would be, say, that you're conducting a study and the participants, or a particular participant or multiple, feel this need to answer all the questions as correctly, or give answers that they think the practitioner would want to hear. So it creates really false results because they're not truly accurate. So you end up creating bias. The definition of bias from your book is a process at any stage of inference tending to produce results that depart systematically from true values. Again, this is an error, and it leads to results or conclusions that are systematically different from the truth. There's a few different types of bias, and we're going to focus on these two here. Selection bias this occurs when you're comparing individuals or groups of people that should not be compared. So ideally, a study should have subjects that are very similar to one another and to the larger population from which they're drawn. So if you are selecting people for a study and you do the study, but then you try to you're trying to apply it to a larger population that they don't even compare to, and they're different from which they're drawn from, this creates a selection bias. So for example, if let's say you withdraw very specific types of people, or people with very specific types of characteristics, or very rare medical history or diseases or things like that, and then you try to use those same results to apply it to the same population from which you drew from, well, you have a selection bias there because they don't truly compare. Measurement bias, the methods of measurement are dissimilar among the groups of patients. So you're measuring patients or groups of patients in different ways, and this creates a measurement bias. Confounding happens when you're trying to, say, find if one factor is associated with another, and the effect can be confused or distorted by the effect of another. So, for example, A study finds those who take antioxidants have a lower risk of cardiovascular disease and certain cancers. However, confounding has been suggested because people who take antioxidants on their own are likely to do other things that decrease these risks, such as exercise, managing their weight, eating more vegetables, not smoking, other things like that. So these activities, not the antioxidants, may be the cause of lower death rates. So you have confounding when you're trying to relate one factor to another, and there's really multiple other factors going on that could be the reason for this, but you just haven't accounted for those things. When you're talking about validity, we have two different types. We have internal validity and external validity. Internal validity is the degree to which results of a study are correct for the sample of patients being studied. So it applies to the conditions of that particular group. Whereas external validity is the degree to which results of an observation hold true in other settings. Another term for this is generalizability. So how valid are our results? How strong is our external validity? How generalizable are our results to the general population? So here's a practice question. Which option corresponds to a threat to validity? Women with thrombophlebitis may have reported the use of contraceptives more completely than women without thrombophlebitis because they remembered hearing the association. Is this a selection bias? If you go back to selection bias, this is when the practitioner makes biased selections of their group, so it wouldn't really match that. Is this a measurement bias? If you go back to measurement bias, this is using different methods of measurement and comparing them. Is this confounding? Well, based on our example, it doesn't really match confounding, and it's not chance, and this has nothing to do with the external validity of the overall study. So the best answer is measurement bias, because we're collecting data on women with and without thrombophlebitis, but those who have had it may have reported the use of contraceptives more thoroughly because of that association. Okay, and we're going to review some of the terms from Chapter 2. These things you will have to know and be able to apply for the rest of the quarter. So, clinically relevant measures of frequency are expressed as proportions. So the numerator is the number of patients experiencing an event, so the number of cases, and the denominator is the number of people in whom the event could have occurred, so it's the population. So for instance, if you had, say, 100 cases of RSV in a population with 400 children, which RSV is most prevalent in, your numerator, would be the 100, and the denominator would be the 400. Prevalence is a fraction. It can be expressed as proportion or percentage, and it's a fraction of a group of people possessing a clinical condition or outcome at a given point in time. So what is the prevalence of RSV in 2003, right? It's at a given point in time. Incidence is a group of people initially free of the outcome of interest that develops the condition over a given period of time. This refers to new cases of disease occurring in a population initially free of the disease. or new outcomes or symptoms or complications occurring in patients with the disease who are initially free of these problems. So incidents, the big thing to remember here is that they are new cases of a disease. There's numerous types of studies, but to compare prevalence versus incidence studies, prevalence studies are people in a population who are examined for the presence of a condition of interest, so for example hypertension. These are also called cross-sectional studies or surveys because people are studied at a cross-section of time. Incidence studies are a group of people having something in common when they're first assembled and then followed over time for the development of outcomes. So these are also called cohort studies. So let's take a look at sampling. Does the study sample represent the population? So a random sample is that every individual in the population has an equal probability of being selected. So you have a sample, or excuse me, let's say you have a population of 1,000 people, you're going to take a random sample of people, which means that every person has equal probability of being selected for the study. A probability sample is every person has a known, not necessarily equal, probability of being selected. Useful when needing small subgroups of a population. So if you're going to study ethnic minorities or the elderly or children, and a random sample of the entire population might not have enough to include them. A convenience sample or grab samples, so these are not random, they were convenient to obtain, such as samples of patients who are visiting a medical facility. So you grab these samples of patients from an area that you work at because it's convenient, and you get people coming into your clinic all the time. So it's not random, but it is convenient. So here's another practice question. A sample for a study of incidence of medication errors is obtained by enrolling every 10th patient admitted to a hospital. So what kind of sample is this? And the correct answer would be C. It's a convenience sample. Again, it's not random because you're not randomly picking patients. You are taking patients conveniently who are being admitted to the hospital. Okay, so most of you should be pretty aware of what a pandemic is, but there's other definitions in terms of geographical area and things like that, so we're going to review these terms below. So an epidemic is a concentration of new cases in time. So an epidemic would be that there's been 4 new cases of HIV in this little town in middle of nowhere where this wasn't the case before. A pandemic is when a disease is especially widespread, such as a global epidemic of particularly severe influenza and the more slowly developing but worldwide rise of HIV infection or AIDS. So hopefully some of you have already heard of this term. When you're talking about the epidemic curve, you're showing the rise and fall of cases of a disease over time in a population. So we saw this constantly on the news during COVID, talking about the curve to look at rise and fall of COVID cases over time in different areas. And so a lot of times on obviously national news stations, they would show it nationwide. Obviously you can break it down to states and cities and things like that. An endemic is when a disease is limited to certain places. So for instance, TB is not endemic in the United States, but it is endemic in other countries. So here's our last practice question. A 25-year-old man from Arizona presents to the ER with cough, fever, and shortness of breath for the past week. A chest x-ray is consistent with pneumonia. Among the considerations for the source of pneumonia is this long word, mycosis, a fungus that is common in the deserts of the southwestern United States and in Mexico, but is uncommon elsewhere. Which of the following best describes this infection? And the correct answer is an endemic because it is confined to certain regions.